Yeah, we're looking good. We've got a really good turnout tonight. So, yeah, we'll get started. So, welcome everybody to our final webinar Wednesday of the year. So, we are here for Let's Talk Upper GI. So, I'll introduce Lizzie in a second, but I'm Alex. I'm the Public Relations Officer for the BPSA. So, I get the amazing job of working with companies like Lizzie and RB. And bringing you guys the best experiences we can along the way. So if you've joined us previously for some of our other webinars and events, you'll know the type of style. But if this is your first one, no problem. It's great that you're joining us tonight. So we will have lots of interactive things for you. So feel free to use the chat function to drop any questions, but there is a Q&A function. So if you drop any questions you have along the way on there, we'll have a look and we'll have a Q&A session at the end. So make sure you get any questions you're thinking of, because the odds are somebody sat watching this as well, asking the same questions. We'll have lots of interactive stuff and Liz will go through sort of how they're going to work. But yeah, so tuck up, make yourself comfy, and we'll cover lots of interesting stuff to get you going. So Lizzie, would you like to get us started?
Thank you very much, Alex. Thanks for the introduction. Welcome, everybody. I really appreciate you spending an hour of your evening on a Wednesday with us to talk some upper GI problems your patients might be experiencing that you can help them with. Before I start the presentation, I would like to ask you all to take part in a little bit of polling. Now, it's not a test. There's no pass or fail here. It's just a bit of fun, but then also it gives you a bit of an understanding as to where you are in your knowledge when it comes to OTC management of upper GI conditions. And we will see whether we can maybe change that by the end of the webinar if you feel like you've learned something, which I hope you all do by the end of the presentation. So information on the screen for you. You don't have to download the app unless if you want to. You can just scan the QR code and it will take you to the web browser where you will get the questions when we get to those slides. As Alex said, my name is Lizzie. I'm Lizzie Horvath. I'm a training and development manager with RB UK. Who is RB? You may not know about the company, but if you have worked in pharmacy before, you may be familiar with some of our products. If I just mention Gaviscon, Nurofen, for example, or Optrex, lots of different products in our portfolio, but today we will be focusing on upper GI. How did I end up working for RB? So I'm a pharmacist. I qualified in Hungary a long time ago in 2004, and I started practicing there. I worked both in community pharmacy and in hospital, and then I was recruited to work in the UK in 2009. And I have worked in various different roles over the years. I've done community pharmacy as well as hospital pharmacy, various different projects. And I was given lots of different opportunities to extend my range of skills. So I even had some nursing training. So I know how to set up an intravenous drip or take blood and so on. So lots of different things that I did over the years. But one of the main focus of my job was always training, whether it meant I was learning something new or I was helping colleagues like an accuracy checking technician with their training, or when I was in the hospital, junior doctors with their prescribing course as well. So lots of different things that was related to training over the years. I even did a second master's course just because I was interested in infectious diseases. So I suppose joining RB as a training and development manager came as a natural progression in my career. So I joined last year and I haven't looked back since. And here I am presenting to you tonight, and I'm very excited to have all of you on the call. What are we going to cover today? As I mentioned, upper GI conditions. What are the primary causes? What could be the common triggers for heartburn and indigestion? And going through the treatment options, we will look at these in line of NICE guidelines. And also I will cover how the recommended products work, what the mode of actions are. As I said, I'm from RB, so of course, I can't go through the presentation without mentioning some of our products within the range, but this is just to help you understand how these work so you can make the best recommendation to your patients. Now, if I can direct you to your Vvox app or browser for the first question, If you have worked with patients before, depending on which year you are in, if you've done your placement already, or if you've done some summer work as a healthcare assistant or dispenser in a pharmacy, you probably would have spoken to a patient who presented with symptoms of heartburn and indigestion. So when you needed to talk to them, how confident did you feel in making that diagnosis? And if I could just get you to vote now, so did you feel very confident in most cases, or confident in some, or did you feel average, not so confident, or you feel like you're still very much at the beginning of your journey of becoming a pharmacist and you're not quite sure what to recommend? And let me see if I've got some votes here. Oh, excellent. I do have some confident people in the audience, which is really good, but I also have some people who are not that confident, or you feel like you're still in training. So hopefully by the end of tonight's training, you will gain a little bit of confidence. And for those of you who feel quite confident, this is going to be a very good refresher for you. Perfect. So you made the diagnosis for your patient. Oh, sorry, I can just see, sorry for the interruption, but I can just see somebody asking about the meeting ID. It's on the top of the screen. So those of you who couldn't find the VBox app, it's presented on the top of your screen. So going back to the questions, if you made your diagnosis and you need to advise your patient what to use in terms of managing the symptoms, are you feeling confident in the recommendation, or on some products maybe, or do you feel like you're still in training? So by now, I'm sure you all casted your votes. Should be coming up on your screen now. Just give it a few more seconds. By the way, as a disclaimer, if you can all hear a bit of a rustling in the background, I've got a confession to make. I've got a 5-month-old puppy who all of a sudden decided to wake up right at the beginning of the presentation, and she's ripping a box apart, so I do apologize. Right. Okay, excellent. Slightly bit different numbers, but we will have a look at these again at the end of the presentation. Very good. So why are we talking about upper GI? If you followed the changes within the UK healthcare landscape, you probably would be aware of some of these changes, but a couple of points to highlight here. In 2018, the NHS introduced the de-prescribing guidelines, which means that for a lot of conditions where people used to get prescriptions for their medicine, now the NHS is encouraging self-care, and they're encouraging GPs to recommend patients to go to the pharmacy for 32 conditions where medication is available over the counter to get this medicine themselves without getting a prescription for it. Then also, if we look at the NHS 10-year plan that was published in January last year, a lot of points within the 10-year plan, including points for GP practices, as well as affecting pharmacies, pharmacy businesses, are all pointing towards self-care, which means patients are encouraged to go and visit their local pharmacy, have a conversation with their pharmacist to get the best possible advice without going to see the GP or even going to A&E. And this also represents itself very strongly in the community pharmacy contractual framework, which is issued for 5 years. So the latest one came out in July last year. And the last addition to this is something that I think is really, really exciting for pharmacists, but also means a lot of extra work. And this is the community pharmacy consultation service that was launched again last year. And we have seen some great results where people have been referred from the NHS 111 services to pharmacy for various different things, including helping them with emergency supply of medicines, but also to help them with self-limiting conditions and minor ailments where the pharmacist will carry out the consultation. So this way, easing the burden on the GP practices and also on emergency care. But all of these steps are pointing towards patients asking for advice. And heartburn and indigestion are conditions among these guidelines, for example, the de-prescribing guidelines, where patients are advised to treat these conditions with the help of their pharmacist themselves. So this is why it's important to understand what is the best way to support these patients when they are turning to the pharmacy counter to get support. So, as I said, the conditions we'll be covering today is heartburn and indigestion. If we think about the gastrointestinal tract, what we are focusing on is the upper GI tract. Some reference books suggest that the upper GI tract should be counted from the esophagus further down, but in the most cases, we would actually class it as starting from the mouth all the way down to the stomach and some part of the duodenum as well. So the digestive process, of course, starts almost as soon as you smell food, or if you have the image in front of you, as it helps to start the process of producing saliva, which is a very important part of the first step of digesting food. And of course, making sure that the food is chewed well, mixed with saliva, and then swallowed in boluses down into the stomach, where the next step of the digestive process is happening. And in the stomach, of course, there are some, various different digestive juices that you need to digest the food. So if you think about pepsin, and also if you think about hydrochloric acid, which are very important in the digestive process as well, to start or continue breaking down the food that you consumed to make it appropriate to pass on to the rest of the gastrointestinal tract. So we are focusing on the upper GI tract and the problems that can occur in this particular part of the body. If we talk about heartburn and indigestion, they are actually not the same. And the interesting thing is that about 73% of patients can actually suffer from both heartburn and indigestion interchangeably. But if you try to imagine it, the best way to think about it is heartburn is a burning sensation that is felt behind the breastbone. As you can see, this flame a little bit further up. And indigestion is something you would feel a little bit lower down. Just under the ribs, in the area of the stomach. It's pain and discomfort that a patient would feel. When they are explaining their symptoms, they can use a number of different words to describe it, but the majority of the cases would describe their symptoms as having an acidic or bitter taste in their mouth. They can feel sick, they might feel bloated, and just a general heaviness, fullness of the stomach. It almost like, it feels like that the food is not moving, it's not being digested well. They can also report burning sensation in the chest or chest pain. And I'm sure a lot of you are already familiar, if you have worked in pharmacy before, with the VAM questioning technique, which is vital, either if you use this technique or something similar, it's vital to establish the various different symptoms the patient are representing, to make sure that you get to the right diagnosis, but also it can help you to identify red flags. For example, if somebody presents with chest pain, is it actually heartburn and indigestion, which the majority of the cases would be, but it can be some other explanation as well. So asking the right type of questions and asking a lot of questions, open questions, where the patient gets the chance to explain what they're experiencing, can help you to make the right diagnosis or establish whether you need to refer your patient. So always feel comfortable asking questions. And if you have the confidence to do so, patients are more likely to open up, especially if it's something that they are a little bit embarrassed about. If we think about heartburn and indigestion, there are some triggers that we are all aware of. So for example, the symptoms of heartburn and indigestion can be triggered by carbonated drinks, alcohol, chocolate, onion and tomato-based products, citrus juices, or if you had a good meal out where the food was a little bit fatty or it was very spicy. But if we think about reflux in general, what do you think is the primary cause of the symptoms? And if you just go back to your devices now, whether you're using a smartphone or an iPad for the VBox app, just select one of these. What do you think is the primary cause of reflux? Is it this fatty or spicy dinner, carbonated drinks, alcohol, or is it stress? I wonder if you, any of you know what I mean by the loss, so dysfunction of the loss, or is it excess stomach acid? Oh, I very much like what I see here. Very good. Okay. Thank you so much for voting. So let's have a look at this. What causes reflux symptoms? So those of you who said that it's the mechanical dysfunction of the lower esophageal sphincter, you were absolutely right. Because this is the root cause in most cases of the development of reflux symptoms. It is a well-known misconception that reflux is caused by acid hypersecretion, but it's only true in a few rare patients. It's not the common cause. What is this loss? I've got a really nice diagram here that can help to explain. The best way to think about it, if you look at this as the stomach, and this is the bottom of the esophagus, here you can see a muscle ring, which is basically made up of two valves, and this is the lower esophageal sphincter. So this ring of muscle opens up to let food in, and it closes to prevent backflow. If we think about what happens if this turns into a problem for the patient, the loss itself opens a lot during the day. For an adult, it can be as often as 40 times in a day. And in most cases, you don't actually notice it. If you think about it, even just like burping after you had a carbonated drink. So in the majority of cases, this does not cause any problems whatsoever. But if it doesn't close properly, or if it relaxes too frequently for that individual, it will allow refluxate to go back up into the esophagus. And this overexposure of refluxate can actually lead to symptoms of pain and inflammation, which will cause the symptoms for the patient. So why do we think this is a problem? So at the beginning, I mentioned when we are starting to smell food, that creates a whole set of processes in the body that will generate digestive enzyme production, all the saliva being produced, as well as also the pepsin and the hydrochloric acid in the stomach as well, to prepare the digestion of the food that will arrive in the stomach. And also in some cases, the bile that is of course found further down in the gastrointestinal tract. In some cases, even that can go back up into the stomach, although it has to be said it's not very common. We're talking about extreme cases here, but imagine all of these harsh chemicals floating back into the esophagus. The difference is that in the stomach, you have a protective lining that will protect the stomach itself from these digestive enzymes. But further up in the esophagus, you don't have this protective lining. So when the food that is mixed with these digestive enzymes floats back into the esophagus, that's what causes the irritation and can lead to potential pathology called GORD, gastroesophageal reflux disease. When do symptoms usually occur? Normally, you can consider this to happen within 2 hours of eating. And this is due to the fact how long it takes for the different types of food products to be broken down in the stomach and move on to the lower parts of the gastrointestinal tract. And food can actually stay in the stomach for up to 4 hours. So the reason this is important to understand, because you would want to suggest something for your patient to use that will last for that long, will last for up to 4 hours to manage these symptoms. And also because it's really uncomfortable, it can be quite painful at times, you want to recommend something that will act very fast for your patients. So a fast-acting product that will last at least for up to 4 hours to help to manage these symptoms. Now, this was a problem affecting the lower esophageal sphincter, but there is also another sphincter called the upper esophageal sphincter, which is a ring of muscle that is found at the back of the throat. Now, there's also another pathology that can develop, and the best way to describe this, how this can happen, is if you think about canned drink, for example, a can of Coke. When you open the lid of that can of Coke, you can hear this hissing sound, and in most cases, you can actually feel those air bubbles as they come out of the container, bringing some of the Coke with it, and it lands on your hand. So your hand might get a little bit sticky from the Coke. And this is exactly what happens. When this gives way, when the loss gives way, there are these air bubbles that are traveling up in the esophagus, carrying some of the stomach content on their surfaces. And this can hit the back of the throat where the upper esophageal sphincter is sitting. And if this passes the sphincter, it can cause symptoms such as a sore throat, excess mucus, or even a sensation of a lump in the throat. And if you think about just the symptoms on the left-hand side, sore throat, a cough, excess mucus, you wouldn't necessarily think about a gastrointestinal problem. You may think about, I don't know, a winter ailment with somebody having a sore throat. But in some cases, these patients are actually suffering from what is called a laryngopharyngeal reflux, also known as LPR. This does require GP referral, not something you would be dealing with over the counter, but there are some products that you can help your patients with to manage their symptoms once the diagnosis has been made. So this is just something that is nice to know that it's a possibility that patients can develop. Now, this was just a general overview of the conditions, heartburn and indigestion. Forgive me for a second, she just got hold of a bag of pens and I don't really like my dog eating ink, so a moment, please. Bag of pens. I am so sorry. So let's have a look at the guidelines. What can we recommend to these patients? As I said, what we are focusing today is the over-the-counter treatment of heartburn and indigestion. But I'm sure you are aware that there are lots of patients who are taking medication on prescription for their symptoms, reflux, heartburn and indigestion. So what we are focusing on is those patients who probably suffer occasionally, or they haven't quite figured out what the problem might be and they need your guidance with this. But always, always bear in mind that you have to ask the right question to establish whether that patient needs to be referred to the GP for further assessment, because in some cases, over-the-counter treatment may not be appropriate. But if it is, what can we recommend? I would like to ask you first, if you go back to your Vivox application, if you have ever come across heartburn and indigestion when you were in pharmacy, or even maybe tried yourself, what would you recommend as a first-line treatment option? And you should be able to see the question on your phone now. Would you recommend alginates and antacids, or just an antacid product, maybe a proton pump inhibitor? What do you think? Okay, this is very interesting. Perfect. I'm very pleased to see the numbers here. So before anything else, the most important thing you need to do for your patients is lifestyle recommendations. And if you look up the NICE guidelines, this will be the first point that they recommend for the patient to try before any other medicine. What sort of things can you recommend? So obviously maintaining a healthy weight is something that you probably are all aware, eating smaller meals, avoiding carbonated drinks as well. So eating smaller meals, avoiding carbonated drinks. Why? Because if you think about it, the lower esophageal sphincter is a ring of muscle that sits on the top of the stomach where it's connecting with the esophagus. If you have a large meal, then of course that is pressing, the full stomach is pressing against this muscle ring, and eventually it will give way and reflux can occur. Same with carbonated drinks, that can also press against this loss, which will then give way. What's wrong with smoking? Apart from all the obvious other problems with smoke inhalation when somebody is smoking a cigarette, one thing we need to remember that nicotine can actually relax the lower esophageal sphincter, and that can also lead to reflux symptoms. So that's another reason among hundreds of others why patients should stop smoking. At the beginning, I mentioned some trigger foods and drinks that can lead to reflux symptoms, so keeping a diary can help. Raising the head of the bed is a very interesting advice. And if you look on the NHS website for recommendation, it's quite funny because what they suggest patients to do is to put bricks under the foot of the bed on the head side. So it might help with the symptoms of reflux, but it may also break your back. So I wouldn't suggest to do that. But if you do want to recommend your patients to raise the head of the bed, what they need to do is to do it from the hips up about 45 degrees. You should never recommend to tilt the head with lots of pillows, because what happens is if they just put a lot of extra pillows under their head, they actually break this section here. And what happens is it won't stop the reflux because the rest of the body is still flat if just the head is elevated. So the reflux will still happen, but the refluxate will stuck in the back of the throat, and that can cause even further complications. So always from the hip up 45 degrees. And just like the same principle for smaller meals, avoid eating closer to bedtime just because of gravity and pressure on this ring muscle that can lead to problems. So your patient has tried all of these, but they're still experiencing the symptoms of reflux. What's next? There are a lot of different OTC treatment options to recommend your patients to try, starting from antacids and alginates. There are some combination products, and for second line recommendation, proton pump inhibitors and histamine receptor antagonists. If we look at first line treatment, those of you who answered alginates and antacids for short-term relief, that was the correct answer. But as I said, it's not a pass or fail. It's more like just to get an understanding as to where we are with your knowledge. So when patients have tried lifestyle measures and it's not helping them for short-term, they should try alginates and antacids to manage their symptoms. Antacids, as it's in the name, I'm sure you all have had lots of chemistry classes, so you probably understand this more than what I can remember from 16 years ago or even longer. But they usually are based around 4 active ingredients, such as calcium carbonate or sodium bicarbonate, although the latter is not a particularly good antacid. What they do is they neutralize the stomach acid to some extent, and this way they elevate the intragastric pH, roughly around 3.5 or so. We don't want it to be elevated much more though, because an acidic pH has got a very important role, has got more than one role actually. It's needed for pepsin to work, but also if you think about infection prevention, an acidic stomach content can actually prevent a lot of infective agents to pass onto the rest of the gastrointestinal tract. So this way they can help to avoid certain gastrointestinal infections from developing. So we don't want to elevate it too much. And by doing so, they can help to reduce symptoms of heartburn and reflux. But one thing we mustn't forget that hydrochloric acid isn't the only thing in the stomach. We also have pepsin, and antacids do not target pepsin. So what do we need to do for this? Using alginates. Alginates have a very unique mode of action. They react very rapidly with gastric acid. They are long-chain polysaccharides. I'll show you this in a second. And their structure is so that when they get in contact with gastric acid, they form a raft. A really nice diagram here that will show this. So it floats on the top of the stomach content, and when reflux is about to happen because the loss is unable to keep closed when it's necessary, it will act as a barrier so that pepsin and the rest of the stomach content actually cannot reach the esophagus. So they are designed to float on the top of the stomach content to avoid the refluxate reaching the esophagus. So they can also trap pepsin and in some cases bile as well. So they create a very, very strong barrier in some cases, depending on the product. So they can help with these agents as well as opposed to antacids, which will work only on hydrochloric acid. I already mentioned these are long-chain polysaccharides, and usually there are 3 types of building blocks. G stands for hyaluronic acid, M for mannuronic acid. So it can be a combination of these, either just GG chains or MM chains, or the combination of mannuronic acid and hyaluronic acid. Now, why is this important? Because not all of alginates are the same, and there are various different things that will influence the quality of the alginate, one of which would be the building blocks it is made of. So if we have very high levels of GG blocks, that will make the raft rigid, which is good because it will last long, but then equally a rigid raft can be pushed away by the stomach content. If it's too soft, so only having the mannuronic acid, then it may not be as long lasting as you would want it to. So in some cases, the best idea would be to have a combination which will make the raft flexible, but also long lasting, last long enough for the patients to have symptom relief for as long as it's necessary. Another thing that can influence the raft strength is the formulation. And this is really important when you look at the various different products available on pharmacy shelves. So aluminium reduces raft strength, but if you look at the product that contains calcium, that can actually increase the raft strength by cross-linking these polymers, these alginic acid polymers. Basically, it looks like an egg box structure, and what it does, the calcium will link these, and they just kind of build on each other, creating this very sturdy structure that can sit on the top of the stomach content. So when we're talking about a good quality raft with a good alginate, as I said at the beginning, I will show you some RB products. So Gaviscon Advance is our best alginate. It contains a double strength alginate if you compare it with Gaviscon Original. And it is stronger and more resilient when it comes to the raft strength than some others that have been tested. So this is something that can last for up to 4 hours. And if I can just refer back to what I said at the beginning, food can stay in the stomach for up to 4 hours. So this is an important fact for the patient to consider when they want something that gives them a long-lasting relief. So what is this test that I mentioned on the previous slide? It's actually a really interesting paper how they've done this. They did an in vitro study where they were looking at different alginate preparations, which can help you to look at the different products when you're recommending it to your patients. So they looked at Gaviscon Advance, which is the alginate product I just showed you on the previous slide, comparing it with our own Gaviscon Original liquid, as well as things like Peptac or Renegii. Now, if you have an analytic mind, the first thing you would probably notice on this slide is that the quantities are different. So for some, they use 10 mils, whereas for others, it's 20 mils. Why is that? Because they compared the maximum single dose the patient is recommended to take of that particular product. So a maximum single dose of Gaviscon Advance is 10 mil, but from Peptac, the patient can or should take 20 mil at a time, up to 3 or 4 times a day, depending on the recommendation. So that's why you see different numbers here. And this in vitro study showed that Gaviscon Advance is indeed 53% stronger when it comes to the barrier strength than some other alginates, and also 12 times more resilient. We talked about antacids and we talked about alginates separately. What happens if the patient would require a combination? Again, referring to a product we have in the RB portfolio, Gaviscon Double Action. Why is this beneficial? Because it has a dual action. It can help with both heartburn and indigestion, because it can work against the acid by neutralizing it in the stomach, and also it can prevent reflux by generating a long-lasting raft in the stomach as well. This is the product. You may have seen it on the pharmacy shelf. Again, it can last up to 4 hours and it works really, really fast in the stomach. I don't know if the video is still available online on YouTube, but that used to be a really, really cool advert. But because we are online streaming, I didn't want to include it in the presentation in case there was a technical issue. But there is a really, really good video online, or used to be, which shows you how the raft is formed. And it's just, it's one of my favorite adverts that I've seen over the years, because it's really interesting to see that it does actually develop into something white and floaty that you could technically touch with your hands. So just to give you context. And also, it does have 3 times the acid neutralizing capacity when we compare it with our alginate product called Gaviscon Advance. So this is the double action product in the range. So just to show you quickly, so Gaviscon Original is the product that has been around forever, which is similar to the double action, but with a little bit of less active ingredients in it. The hero product in that sense is double action, which works on heartburn and indigestion as well. And then Gaviscon Advance with the strong alginate, as I mentioned before. So this was first line recommendation. Your patient has tried lifestyle changes, didn't really give the relief they wanted. Then they moved on to first line treatment option with OTC medicine. They tried some alginate and antacids. And then you checked that they had the right compliance, taking the medication at the correct time with correct dose as well. And they're still experiencing the symptoms. So what can you recommend then? The second line treatment recommended in NICE guidance is moving on to proton pump inhibitors, but only if alginates and antacids have not relieved the symptoms. Proton pump inhibitors or PPIs, so these inhibit the gastric secretion of hydrochloric acid, and they do this by blocking the proton pump in the parietal cells. And I've got a bit of a diagram on the next slide on this. They are used for all sorts of different things or different conditions related to excess acid production in the stomach. Most commonly, it's used as part of a complete treatment in H. pylori management, used in gastric ulcers or GORD that I mentioned before, gastroesophageal reflux disease. But then some of them are used for very specific conditions, for example, for patients with cystic fibrosis. Now, what I would like to focus on is PPIs available over the counter. So there are 3 PPIs available over the counter in the UK. Esomeprazole, omeprazole, and pantoprazole. The second 2 are prescription only. So what are these parietal cells? So this is just an enlarged section of the lining of the stomach. And these are your parietal cells, which have these proton pumps, which secrete the hydrochloric acid into the stomach. So when you're administering a proton pump, it binds to, when you're administering a PPI, it binds to the proton pump, and it will block the secretion of the hydrochloric acid into the lumen of the stomach. These can the effects can last for up to 24 hours, but if the patient is new to using a PPI, it may take actually about 2 to 3 days for the PPI to take full effect. Again, coming back to some RB products. So we have a PPI available on the market in OTC form. It's called Guardian, and it contains 20 milligram esomeprazole in gastro-resistant tablet form. So the product claim is that the tablet starts to work in 1 hour and it can last for up to 24 hours. But I just want to refer back to what I said previously. When the patient starts taking this first, it may take about 2 to 3 days to take full effect. Now, one thing that is important to remember, that we are talking about OTC use of a PPI, and the recommendation is that at OTC use, patients should use it for up to 2 weeks and not longer than that. So if after 2 weeks, the symptoms are not resolved, the patient should come back and have another discussion with the pharmacist and have a conversation about potentially having to go to the GP for further assessment. Now, if we think about PPIs, and this is true in general, not just esomeprazole, that a really interesting thing that is often overlooked, that about 40% of those patients who are taking a PPI, for example, esomeprazole or omeprazole, can experience breakthrough symptoms as often as 2 to 4 times a week. Breakthrough symptoms, what I mean by this, they actually get reflux again, despite of using a PPI and using the PPI correctly and regularly. And 65% of these patients who experience breakthrough symptoms can suffer from this at nighttime. The problem is with that it can disturb their sleep, which means that it can affect their daily life as well. And the really interesting fact is that a lot of these patients, 40% of them just put up with the symptoms, the breakthrough symptoms. They don't actually speak to their GP about this. And this is where you can help the patients understand what a breakthrough symptom is and how to manage it. So one thing that patients can use to manage breakthrough symptoms is using a good quality alginate, for example, Gaviscon Advance. And Gaviscon Advance is actually licensed to be taken alongside PPI to manage breakthrough symptoms. What do we mean by this? It doesn't mean taking it at the same time. It's really important. There has to be a 2-hour gap. But to manage those breakthrough symptoms, given that there is a 2-hour gap, Gaviscon Advance as a good quality alginate can help to manage those breakthrough symptoms. So something to consider when you're talking to a patient who's already on a PPI, understanding that are they suffering from breakthrough symptoms? Because often the solution isn't increasing the dose of the PPI because it may not be solving the problem anyway. It's a case of managing lifestyle. Does the patient need to lose some weight? Do they need to review their meals? Or is it a case of they are suffering from breakthrough symptoms and they need to use an alginate as well as a PPI? As a +1 for the second-line treatment recommendation, one thing I wanted to mention here is H2RAs, histamine receptor antagonists. So those patients who didn't respond well or didn't respond at all to PPIs, H2RAs can be recommended. Now, if you have been in pharmacy last year at some point, or even this year, maybe before March, then you probably would have heard about a recall of ranitidine OTC as well as POM. So at the moment, this is part of the guidance still, but currently over-the-counter H2RAs are not available. But just to give you the full picture, what are these? So histamine receptor antagonists, what they do basically, they block a particular receptor in the parietal cell. So if you look at the parietal cell, which you can see on the diagram, it's just an enlarged section of the lining of the stomach. You've got a couple of receptors here. So you've got the acetylcholine receptor, gastrin, and histamine receptor as well. And then you've got your proton pump, of course. And if you use a histamine receptor antagonist, what it does, it will block the histamine receptor, and this way it can inhibit the acid secretion to some extent. But as I said, over the counter at the moment, this is not relevant. Just very briefly, I wanted to mention something about infant reflux. And I think this is really interesting because it's one of those conditions where you don't really discuss much about in the pharmacy, but you are in a good position to have a conversation with a worried mum, because witnessing infant reflux is not particularly pleasant. It's also known as gastroesophageal reflux. The difference between this and the adult version, that is called the gastroesophageal reflux disease, GORD, when we're talking about reflux in adults. This is gastroesophageal reflux. It's just basically the concept is very similar. Gastric contents pass through from the stomach into the esophagus. The reason this happens because with babies, their esophagus is usually underdeveloped, particularly early on in their life. And also they are on a very high calorific diet, that is a liquid diet, whether they are breastfed or they are on a formula. The symptoms usually start before the age of 8 weeks, but in the majority of the cases, it does resolve without treatment within a few months, but definitely by 12 months to 18 months of age. But of course, it's quite concerning because the baby might bring up quite a lot of the stomach content, and the mum or the parents might be worried that the baby won't be developing well. So in those cases where they need additional support to manage gastroesophageal reflux in babies, what would be recommended for them to use is Gaviscon Infant. Now, this is also an alginate product. However, it works differently from the other alginates in the Gaviscon portfolio. And I guess this is the reason why I wanted to include this in the presentation, because just how differently it works. So as I said, alginates are different, they're not all the same, and sometimes they have a slightly different action in the body. So for example, what this does is when it reacts with the acidic stomach content, it will form a viscous gel, which will then stabilize the stomach content. So if you think about alginates that I talked about before, they form a raft, whereas this will create this viscous gel within the stomach content. And this way it can stabilize the stomach activity and reduce the chances of this reflux happening, reduces the incidence of it. One thing to remember here, that the licensing doesn't allow you to sell this for babies under 12 months over the counter. So if you read up the patient information leaflet or the summary of product characteristics on the EMC website, you will see this. So most parents will get this on prescription from their GP. Between 12 months to 2 years, this is something, if they need, they can purchase from the pharmacy. Not very common though, but it's something for you to be aware of. And just a quick recap what we have within the RB Gaviscon portfolio. So if you're looking for an alginate for your patients, just remember Gaviscon Advanced has got the strongest and most resilient alginate. But we also have the Gaviscon Double Action, which will help with heartburn and indigestion as well. And then we have our PPI in the portfolio that can help with those patient symptoms where they tried alginates and antacids and it wasn't successful. This little guy in the corner that you can't really see very well, that's our, or was our H2RA, which is currently not available due to the nationwide recall of all ranitidine products. So before I wrap up, and we are coming to the end of our hour anyway, so I think in terms of time it's June anyway, I'd just like to ask some more questions. So, based on what you've seen in the presentation, do you remember what the NICE guidance recommends as first-line treatment for heartburn and indigestion? Is it a proton pump inhibitor? Is it a histamine receptor antagonist? Would it be an alginate or just an antacids, alginates and antacids? Just use your VBox app and tell me what you think, what the first-line recommendation would be. And let's have a look at the answers. Yay, excellent. So just remember, once patients have tried lifestyle changes and they need an OTC treatment as a first-line recommendation, it is indeed alginates and antacids, so well done. If the patient is suffering from breakthrough symptoms, even though they are already taking a PPI, what can be recommended for them to take or to do to manage the symptoms? Would you recommend an antacid? Would you recommend to increase the dose of the PPI, add a H2RA, an alginate, or would you recommend an alginate and antacid combination? Have a look at the answers. Okay, so a bit of a mix there. So the recommendation is that if somebody is experiencing breakthrough symptoms whilst taking a PPI, to give them alginates to manage these breakthrough symptoms. However, an alginate and antacid combination might be also appropriate. Histamine receptor antagonist in addition, or increase the dose of the PPI, would have to come from the GP after some careful consideration. It could be the necessary solution, but as a standard first step, what the recommendation would be is to add an alginate to manage these breakthrough symptoms. Well done. So now you've seen the presentation. These are my last two questions. We had some numbers at the beginning about confidence in diagnosing and confidence in advising your patients. So I would like to see how confident are you now on diagnosing patients when they're presenting with heartburn and indigestion. And you should be able to vote now on the VBox app. Oh, excellent. Really, really good numbers in the confident and very confident range. And I'm very thrilled to see this. Excellent. Thank you so much for this. Just shows me that you hopefully paid attention and were able to take away some knowledge from the presentation. So if you want to see what that means, this is where we started at the beginning of the webinar. And this is where we are now with confidence. So I'm really, really pleased to see all of these numbers changing. Thank you. And I believe this is probably my very last question. So you've diagnosed your patients. How confident are you now on advising them on heartburn and indigestion? And let's see whether we can see some confidence increase here as well. Now. Fabulous. Oh, I'm so pleased to see all of these numbers. So let's have a look at the changes. Ooh, just thinking about it. Lovely. Oh, this is excellent. Alex, I think you've got some good numbers here to take away after tonight's webinar. So thank you so much for everybody for playing part in the polling. And now it's over to you. Hopefully I could see in the chat box, I wasn't reading all of them, but you have asked some questions. And I saw some people ask if they can see the dog as well. So she's gone terribly quiet outside. I'm a little bit worried. So I will, if the very end after we've done the pharmacy business, those of you who want to have a little look, I will bring her in. But let's do the questions first.
Brilliant. Thank you very much, Lizzie, for that. And I can see that we've got a lot out of that. So whether you're a first year student or pre-reg that's joined us, going over this material will help you along the way. So Lizzie, thank you very much for going through that. But yeah, we've had lots of people both in the chat and the Q&A function. So we'll go through as many of these as we've got time for before we bombard you with questions, and then we get to see the dog if you're happy with it as well. That was one of the most asked questions in the chat as well, so very funny to see.
Okay.
So just to get us started, so going through how do you differentiate between LPR and GORD, and then when would you make a referral with that?
It's a really good question. It's mainly to do with where the patient is experiencing the symptoms. So with LPR, they would always have symptoms affecting the back of the throat. If you guys recall on that slide, there were a list of symptoms that can be easily mixed up with a simple winter cold and sore throat. So you've got a sore throat, excess mucus, particularly if it feels like postnasal dripping, a lump sensation, and even hoarseness. So if that is a set of symptoms the patient is experiencing, that is definitely, and you can, of course, exclude a winter cold or a sore throat as a reason for this, caused by a viral or bacterial infection, then in those cases, you would have to refer the patient. With GORD, gastroesophageal reflux disease, the symptoms are developing further down, mainly focusing just under the rib, but it can be also kind of related to that heartburn sensation as well, feeling it in the middle of the chest also. Really good question though, thank you.
Brilliant, thank you. And obviously you touched upon the infant range and what we can do for after 1 year of age. Is there any preparations for ages below that?
So as I mentioned earlier, Gaviscon Infant is the product, but it needs to be prescribed on prescription. The reason being because these babies and the baby's esophagus is still developing, if there is concern that they have the gastroesophageal reflux on a regular basis, they need to be monitored by the GP. There are some things parents can do, so even changing the way they feed the baby, they might need to change to a specific type of bottle from breastfeeding, not necessarily changing to formula, but pumping and then feeding through a bottle, which can help so that the baby doesn't swallow that much air. There are all sorts of different types of aids that are designed for this, but it can also be an indication of some other problems. Is there intolerance involved? Is the baby lactose intolerant, or is there some other issue there? So for the first 12 months of life, the baby needs to be assessed and monitored by the GP and make a decision whether it is just a simple reflux that can be managed with, for example, a product like Gaviscon Infant. And if so, then the GP will prescribe it. If it still kind of lingers from 12 months of age onwards, then if necessary, the mum can manage it with over-the-counter medicine, because by that point, the baby would have reached a development level where that close monitoring isn't necessarily required. And also in a lot of cases, by 12 months, babies would be weaned off. Not everybody, but a big majority of time, they would be weaned off of either breastfeeding and definitely from formula. So it's less likely to happen anyway. Again, another excellent question.
Brilliant. Yeah, we've still got a few more left. So if we're all right with you to keep going through them, yeah, perfect. So somebody's noticed that the active ingredient in some of the products, some of it's sodium bicarbonate, the other is potassium bicarbonate. Why is that the difference? That's so in the Gaviscon Advanced range that we use potassium bicarbonate.
Very good question. So if I can just go back to that slide. I go back to the slide. So it's to do with the formulation. Potassium bicarbonate is actually not in the product. Oh, here we go. This is the slide I wanted to show you. So potassium bicarbonate in this product, and we're talking about Gaviscon Advance here, where we're focusing on the alginate aspect of the product. Potassium bicarbonate is a very, very poor antacid. But what it does, it actually helps the development of the alginate raft, because as this hits the stomach, it starts to develop these gas bubbles that will help to float the raft. So it's a really excellent question. So here the focus is the raft strength, whereas if you're using sodium bicarbonate compared to potassium carbonate, it's a much better, still not the most excellent antacid, but still a much better antacid, especially if you also have the added calcium carbonate. So the two of them together can actually help to create that antacid effect, as well as creating a good raft by supporting the sodium alginate as well. So that's why you've got a different type of additives, because of the purpose they serve within that particular product.
Brilliant. Yeah, and sort of following on from that is if you've got the choice of Gaviscon Double or Gaviscon Advanced, which one, what would make you determine what you'd offer?
Cheeky question. So unfortunately, this is where your training and experience and confidence comes into the picture, because it very much depends on the individual patient. Okay, so for example, you've got somebody who, let's say, I'll give you a patient example, random one. A gentleman in his 40s, looks reasonably fit, definitely doesn't look overweight, doesn't smoke, does regular exercise, but every once in a while, he likes to go out with some friends and have a good spicy Indian dinner. And he knows that that is one of his trigger foods, and it will upset his gastrointestinal system, and he will develop symptoms of reflux. For him, because he doesn't suffer very often from reflux symptoms, hardening and indigestion, I would go with Gaviscon Double Action, because it will help to manage the symptoms, because the patient doesn't suffer very often. It might be difficult to determine whether it's heartburn or whether it's indigestion or a combination of both. However, if you have somebody, for example, during pregnancy, it's a very well-known fact that during pregnancy, as the pregnancy advances, because of the size of the fetus, the hormonal changes, as we know it, as the pregnancy develops, the pregnancy advances, you start to produce a lot more hormones that prepare the body for birth. And some of these hormones will relax smooth muscles like the lower esophageal sphincter. So the more advanced you are in the pregnancy, the more likely you will develop reflux symptoms. So for this case, because it's a simple reflux, stomach content is floating back up into the esophagus, an alginate would be more appropriate. I hope that makes sense. So it depends on the patient and what is likely to cause the symptoms. If it's difficult to determine if it's heartburn and indigestion, or the patient doesn't suffer very often, go with double action. But if it's definitely just reflux, for example, pregnancy, go with Gaviscon Advance.
Brilliant, thank you. Yeah, we're definitely asking you some really serious questions here, and next one will be a really big test for you as well. So revision for you as much as it is for us.
Okay, let's have some water first.
Yeah, it's a big one. So with somebody that has hypertension, obviously these products contain a lot of sodium. So is that appropriate and safe to use?
So the answer is depends on the patient and depends on the product. Now, if the blood pressure is under control and they are regularly monitored by the GP, and otherwise they're monitoring their salt intake, basically just not adding a lot of extra salt on their chips when they're going for fish and chips or something. But I guess somebody with high blood pressure problems shouldn't be eating fish and chips on a regular basis anyway. So if the patient is stable, there is no extreme restricting factors, and their blood tests are coming back normal, then as long as it's taken into account, they are safe to use. If you compare it with a lot of other products available on the market, some of the Gaviscon products actually come out better in terms of sodium content. But this is where the summary of product characteristics can be a huge help. So if you go onto the Electronic Medicines Compendium website, the EMC website, for the Gaviscon range, for every single product, you will find the sodium content specifically highlighted in the information. So you can use that to compare different products from the shelf and select the one that's most appropriate for the patient. It's not a black and white answer, I'm afraid. Again, it depends on the patient. You need to understand a little bit more about that particular individual. But in most cases, unless there is an extreme restriction on sodium intake, these are okay to use.
Perfect, thank you. Definitely putting you on the spot with that one. So we've just got a couple more and then we're going to have to wrap up, I'm afraid. But sure. This next one, so if somebody's taking both a PPI and an alginate and antacid, which one would you take first, and why is it that you take that 2-hour gap?
Really good question. So if you have a product that contains an alginate, as I said, what happens is that it forms a raft on the top of the stomach content. So this 2-hour rule is true for anything, not just a PPI, any other medicine, because basically what happens when the raft forms, it can trap other medication, or it will potentially stop, if they are taken in the wrong order, the medication to actually get into the stomach, because it can just sit on the top of the raft. So think about it as a physical barrier, which you have to take into account when the patient is being, the medication is being taken. It's not a pharmacological interaction as such. It's more like a physical interaction you have to bear in mind. In terms of the order, what I would say, if somebody takes a PPI, from my experience as a pharmacist, majority of your patients will take that PPI first thing in the morning. In some cases, preferably before breakfast, depending on the active ingredient, or at least sometime in the morning hours. When you're taking either Gaviscon Advance, which is an alginate, or Gaviscon Double Action, which is an alginate antacids, These are recommended to be taken after food anyway. You should never take them before food. So that already provides you a bit of a gap anyway. But the order always is PPI first, then have your food, and then sometime afterwards you can take your Gaviscon products, provided that there is a 2-hour gap.
Brilliant. And we'll take this as the last one. So you've obviously talked about OTC PPIs. Somebody's asked about the long-term use of using PPIs, linking it with how it affects bone density in the long run. How would you sort of go about considering those investigations and how we manage that?
Really good question. So if you look up recent prescribing guidelines, there is something that becomes a trend called step down, step off of PPIs. So the reality is that a lot of patients, and this is no judgment to any healthcare professional, this is just kind of a current reality that is being recognized now, that a lot of patients are on a PPI unnecessarily. So the recommendation and the expectation is for patients on PPI to have a yearly review. Let's have a look, do they still need it? If there is a chance that they may not need it, for example, they were prescribed a PPI when they were in hospital to have a hip replacement, but they don't actually need to take it long term, but it was just forgotten and it's on their repeat prescription, then these patients need to start stepping down from their PPI and eventually stepping off, meaning stopping it, because indeed there are some long-term effects we need to consider. So what has been shown in data and research that PPIs can affect the absorption of certain minerals like calcium. So that can have long-term effects and predispose patients to osteoporosis. But unfortunately, there are a lot of other complications that are linked with long-term PPI use. So for example, interaction with other medicine. Also, if you think about what I said around the stomach pH, it is a known fact that people, especially in hospital, if they are on a PPI, they can develop Clostridium difficile infection in the community as well as in hospital. It's a horrible thing that needs to be dealt with for the nurse who needs to deal with this. So there are lots of considerations, but ultimately the rule is patients need to be regularly reviewed and if possible, either step down the dose or completely stop the PPI, because yes, osteoporosis is a known risk among some other things as well.
Amazing. I'm afraid that is going to have to be the last one, both to give you a breath, but also we've had a lot to reflect on tonight. So Lizzie, thank you very much for going through that. I know myself, it's given me a lot to go over and really good revision for me, as I'm sure everybody listening will do as well. So thank you very much, Lizzie, for your time and that amazing presentation.
Thank you, Alex, for facilitating it. Thank you, everyone who was on the call and took part in the interactive sessions and voted. I really do appreciate it. I suppose the next point you probably would have expected anyway. Please don't hate me for it, but I'm going to send out a survey. Hopefully, it will work through the Vvox app. If you don't receive it, it's no problem. But if you are able to send some feedback, I would really, really appreciate it. And it helps us determine what you guys would like next time when the BPSA team and my team will discuss potential future webinars and any other collaborations. So thank you so much. I really, really do appreciate it that you spent your Wednesday evening with us. And for those of you who are interested, I'm going to go and get the dog now.
Perfect, amazing. So if everybody wants to hang around both the dog, but also we're going to have a quick little chat about what's happening within BPSA at the minute and in the new year. So we won't keep you for too much longer. We know it's getting near Christmas, everybody's probably quite tired, and you've joined us for a good amount of time already. So we'll see the dog. We'll hang around for 5-10 minutes afterwards to have a bit of a chat. But here's the most important event of the night.
Hello, everyone. So this is my 5-month-old puppy who just ripped open a cardboard box of delivery that I had today. So I'm going to go and clean it up now.
Amazing.
But yeah, thank you so much again. Any feedback is much appreciated. And if there are any questions afterwards, please send it through to Alex, and I'm happy to come back to you guys with anything further. Okay. Thank you so much. Alex, are you happy for me to drop off the call now, or do you need me for anything else?
Yeah, no, that's brilliant. If you want to sign off, I'll let you get back to your dog.
Thank you
and enjoy
so
the
much.
rest of your evening. Thank you very much.
Thank you, everyone. Have a wonderful Christmas. Or somebody just asked the name. One more thing, just because she's a Hungarian Vizsla, she's got a Hungarian name, and it's Lepke, which means butterfly in English.
Beautiful.
She's not a butterfly right now. She's doing. Anyway, once again, thank you so much, everybody. Have a wonderful Christmas break and Happy New Year. And I'm sure I'll see you all at the next webinar. Bye.
Thank you very much, Lizzie. Thank you.
Thank you. Bye.
Right then, guys, thank you for listening in. And it's obviously been a really amazing opportunity for you guys, whatever point you're at. So we are just going to have a quick couple of minutes talking about a few things that we are doing within BPSA over the next